This is 3Q's interviews. We're here with Dr. Riley. Dr. Riley was my pulmonology small group facilitator. Would you like to introduce yourself?
Sure. I'm Craig Riley. I was a former Pitt medical student. I did my internal medicine training, my pulmonary and critical care training, and I'm still here as junior faculty in the Division of Pulmonary, Allergy, and Critical Care Medicine.
Awesome. And you're involved in the medical school and teaching. Can you speak a little about how that incorporates into your practice?
Sure. I think that, well, I'm here because I'm interested in teaching, I suppose. And I got interested in pulmonary and critical care actually when I was a second-year medical student going through the course that you just completed.
Yeah.
And I continued to work very closely with my small group facilitator, John Crite, for many years after that. So that certainly left an impression on me, and I think that teaching both gives you an opportunity, like me as the teacher, to reinforce my knowledge, and I learn a lot of stuff from you guys, although I try not to let that on. But it's also a great way to stay engaged and to be able to build on some of the experiences that I had in the past here and that I had through all different levels of training, and be able to try to pay that forward in some respects.
That is something that medical students have to deal with, is deciding whether they want to stay in academic medicine or go into private practice or anything like that. And so that's a good perspective, being able to teach and have that continual debate about, academics is important, and giving back is also important. So you said you decided in your second year you wanted to work in pulmonology. Can you speak a little to that?
Yeah, I tend to make decisions and run with them. So I don't know if that's the best approach for your audience to take. But one thing that I really liked about pulmonary when I did the course, and that I've continued to like, is that there's a very clear way that physiology applies. So all that stuff that you're learning about in the first 2 years of medical school doesn't just disappear. Mm-hmm. Understanding pressure-volume relationships in the lungs is really intrinsically important to what I do managing patients on the ventilator in the ICU, or seeing somebody who's short of breath who comes to see me in clinic. And I really like to be able to delve into why people are experiencing what they're experiencing with the underlying physiology. I think it both helps to inform the treatment that I give people in those situations, but it also keeps me engaged when we come back and we teach these equations that you think you're never going to use again, and then it turns out that they explain what you're actually seeing for real patients in real life.
Yeah, that's awesome. So you said you manage patients in the ICU. Can you talk about what a typical day looks like for you here at the hospital?
Sure. So I think one of the important things that I should stress is that for a lot of people in pulmonary and critical care, and certainly myself included in that, a typical day is an elusive concept. So I see patients in the clinic. I see patients on medical floors as a consultant or as a primary team. I see people in the intensive care unit as a consultant and as a primary team. So I wear a lot of different hats. I think that although I do less of this, some of my colleagues are very involved in doing procedures, some of which can be prolonged or involved procedures. So a typical day is really hard to define for somebody in my field. I think that that's actually one of the big advantages. So for people who kind of like everything and they want to do it all, they like have their hands dirty and do procedures, but they want to have longitudinal relationships with people that follow up with them in the clinic over the course of years, who also might want to take care of very sick people in the hospital, making life and death decisions and dealing with real interesting acute pathophysiology. You can do all of that in pulmonary and critical care. And although you can do that in some fields, there are a lot of areas where you're squeezed to differentiate yourself these days. And so I think that having that opportunity to be a subspecialist, but in many ways still a generalist, to do some procedures, but to still be a cognitive specialty, I think that that's a really appealing thing for my field, and certainly one of the reasons that I did it.
That does make it interesting. Do you have a lot of control over your day-to-day schedule, where as far as if somebody, like once you get into practice and you start realizing, I kind of like doing more of the procedural things, or I kind of like dealing more, how do you get to determine how that works?
Yeah, that's actually an area that we have a fair amount of control over, at least longitudinally. So some people in pulmonary and critical care end up really liking outpatient practice and end up doing exclusively outpatient pulmonary. Some people, a lot of people, will do exclusively critical care. And some people still manage to do it all, although especially for those of us that have other draws on our time, like protected research time, NIH funding, then when you're slicing up a smaller piece of the pie, it can become more challenging for that. So I think that deciding that you want to do everything, well, you might not be able to do everything if everything also includes teaching and research and administrative tasks.
Yeah.
But as a clinician, you could certainly do everything in pulmonary and critical care, and even as somebody who does research and teaching, you can do some things, just maybe not everything.
So you kind of start to funnel down as you get, higher, more responsibility in the administrative setting or in the research as you get grants and things like that. So that's kind of good perspective, that you kind of have a little more tailored control over the exact specifics of your career.
Yeah.
Okay, so we'll do our 3 Q's here. First question, what's your most interesting thing you carry in your white coat?
Well, I guess a lot of the time I'm not wearing a white coat, so I try to, as a lung doctor, any self-respecting lung doctor should have a stethoscope. I have the same stethoscope that I had when I was a medical student in Pitt, so I have not upgraded and I have not needed to. But the stethoscope, in addition to listening to people, that's my reflex hammer. That functions as a lot of different things.
The Swiss Army knife.
It is. It's very much the Swiss Army knife. And I occasionally have to use an electronic one when I do telemedicine, and I'm still not a fan of that. Huh. I'm not a fan of those disposable yellow plastic ones either.
Oh, I've used the yellow ones, yeah.
I'm a much bigger fan of the bleach wipe and your own stethoscope. But that's as close as I get. One of the things that I like about working in the hospital is the ability to wear scrubs. And I put on the white coat and play the part when I'm an outpatient doc, but when I'm in the hospital, I see a lot of people with some nasty infections, so I try as much as possible to just be in scrubs and get rid of those when I get home.
That's a good idea. Okay, question number 2, what's a fun fact about pulmonology?
So I guess a fun fact about pulmonology, well, I already alluded to this, but I think that one of the best things about it is the ability to practice such a breadth of medicine. Mm-hmm. You're still really grounded. There are a few areas that don't touch to some degree on pulmonary. So there's a big overlap with infectious disease. There's a big overlap with rheumatology. There's a big overlap with cardiology, certainly. But you get to be a subspecialist who has to stay up on the rest of your medical knowledge. And like I said, you still need to be, you can be a proceduralist, you can manage patients in a bunch of different settings. I think that there's really no doubt. There's no person who couldn't find a niche within pulmonology.
That's great. Final question. So what is a common misconception about vaping, or can you speak about vaping? It's been in the news a lot lately.
Yeah, so obviously a very hot button issue. I think that while there's still a lot of questions about what specifically in different vaping products is triggering a lot of this acute lung injury, which we see a ton of here, and our fellows published a case series in a pretty high impact journal about this. There's been some implication that some of the additives, including vitamin E acetate, mm-hmm. might be part of what's triggering some of this acute lung injury. Probably the most important thing to know, though, is that we've seen a spectrum of different types of acute lung injuries that are unlikely to be caused by one specific thing. And for, while people who are vaping these THC, oil-dissolved products certainly seem to have more issues, I've seen patients in my clinic who come in who are having new onset respiratory issues in the setting of using commercially available products like Juul.
Wow.
So I think that we know from some early studies that if you take airway cells from people with otherwise healthy lungs who are using vaping products versus people who are smoking cigarettes, traditional cigarettes, you see similar levels of inflammation, but different inflammatory signatures. So I don't think that this is really safe for anybody, and while I'll make an exception for the medications that we prescribe people to inhale, other than the air that we're supposed to breathe, I don't really think that any of these chemical products are safe for long-term inhalation, and I certainly don't recommend them to people as a way of getting off of traditional cigarettes. Yeah. That's certainly not, although that's the way that they were initially intended to be marketed, that's not the way that these companies are marketing them. Sour Patch Kid.
Yeah, exactly.
E-cigarettes are probably not marketed to your 60-pack year history of smoking, 70-year-old guy.
Yeah, that's interesting. That is like how it came out. Oh, it's safer than cigarettes. It's better than cigarettes. It's such a good alternative. But like you're saying, you published some information that says that it's not, and that we haven't seen the long-term studies yet. And so that's kind of what we're waiting on.
Well, we won't see those long-term studies until they've been out for a long time. So I think waiting 20 to 30 years to find out that people are developing pulmonary fibrosis to a higher degree or are getting emphysema or some other chronic lung disease, well, the horse is out of the barn at that point in time, and it'll be another few decades after that before we figure out how to treat the after effects. And I think that the safest route for now is just not to do those things, and we need to find better ways at the government level of regulating this stuff before it becomes an even bigger problem. It's a ridiculous number of high school kids that are using e-cigarettes these days. Some numbers like 40%. It's really concerning.
And it's just extremely addictive, and once you form that habit, it's hard to stop.
Yeah, and the nicotine is less regulated in this, so some people, you're getting a bigger hit, a much more concentrated dose. So in many ways, it might be more effective and potentially more dangerous than cigarettes.
Well, thank you, Dr. Riley. Appreciate it.
Sure.